Good afternoon. Welcome to Propofol, Ketamine, Benzodiazepines, not just Versed, and Precedex. Are they the same or are they different? And as bedside providers, what should we be considering when we're administering these agents to our patients? So first and foremost, it's really great to kind of have an overview lecture. I'm not really like talking about biodynamics and excretion or anything. There may be an occasional little thing about it, but mostly what I'm talking about is what is it we should be expecting when we're at the bedside and how are we going to deal with it? What should we be monitoring? What should we be evaluating when we're giving any one of these agents? And by the way, none of them are the same. Sort of like that old Sesame Street song. None of these things is just like the other, right? Not one of these things is not like the other, but none of these things are just like the other. They're each in different classifications. And what that means to us is that we actually have to be very clear that we want to be able to observe and evaluate these different agents when we're administering them. So just as a reminder, when we talk about goal of intensive care comfort, number one is to relieve pain. That is always the most important. That's always going to be our first concern and initiative when we evaluate patients. When we're considering that they may be behaving in an agitated or anxious manner, the first thing is to assure that we relieve pain. Now, I'm not talking about pain management here. I'm not really talking about how do you evaluate pain? Are you using a CPOT? Are you using BPS? Not really talking about pain, but remember, that's always the first goal, is to relieve pain. The next goal is to alleviate anxiety. And when we are making decisions about alleviation of anxiety, our focus has to be, we want to facilitate ventilation and ventilator synchrony. We want to be able to manage the patient without them feeling any more stress or extraordinary stress in the situation. We'd like to reduce some of their physiologic catecholamine-enhanced stress responses. And by the way, catecholamine-enhanced stress response is really bifold: tachycardia and systolic hypertension. So you gotta kind of put that into your mind when you're thinking about evaluating your patients. And last, and certainly not least, is we would like to use medications that actually promote sleep, not reduce it. So that's going to be a really important perspective in determining how we would like to use our sedating agents, because patients look like they're asleep. That doesn't mean that they are asleep. So again, these are going to be our goals when we talk about intensive care comfort. This is a fantastic visual. It's old as the hills, probably older than some of you. It was actually first published by Crippen and others in critical care clinics, and then used by Maureen Harvey in the American Journal of Critical Care Medicine. Some of you might know her. She was the first nurse president of the Society of Critical Care Medicine. Her focus was very much about patient and family integration in the ICU. So it was really important. And when we look at this visual, you can see that even in 1990, the discussion was, how do we control anxiety without producing delirium or delirium psychosis? So that was way before the days of Wes Ely and the CAM ICU tool for evaluating and measuring delirium. So I mean, talking about delirium is incredibly and profoundly important. By the way, I'll be going to the Ukraine to train trauma surgeons and ICU nurses in August, and part of that training will actually be about anxiety, delirium, and delirium psychosis in the management of critically ill patients. So it's a worldwide issue, not just an American issue, not just your unit, a worldwide issue. But what we want to remind ourselves is, as we try to tease out anxiety, there are many things that occur in the ICU that we can't control, and there's a few things that we can control. So one of the really important ones is to appreciate very much the room temperature and noises and lights. These generally are things that we can control. So many of you, I'm positive, have instituted quiet time in your ICUs. Typically that begins at around 9 p.m., maybe a little later, maybe a little bit earlier. Lights go down, voices are down, much quieter, alarms are turned down. We can't continue the daily buzz in our ICU. So that's a really important thing that we may be able to control. Cooler room temperature, reduce noise, and reduce lights. And frequently that can be a hard thing for you to control in your ICU, but it is something that as nurses, you can decide to implement in your ICU. Immediately, that gives a differentiation between day and night, which is really important. Another really important perspective is the non-changing environment. So about 11 or 12 years ago, I started talking about projection. I had a great idea. Somebody beat me to it. Projection on the wall of the ICU of daytime, evening, nighttime images, and how that changing environment could actually collate your patient's confused state where they're not really seeing a difference between day and night, helping them to understand day and night. Lots of folks, I talked to a lot of people about it. Many folks said, well, that's going to be even more confusing to the patient because they're going to think they're camping out somewhere. They're not going to understand where they are. But someone else in Israel actually developed a tool of a changing environment, not necessarily day-night rotation, but just a changing visual environment. So that is something else to think about. I would say that unless you have a system that is willing to invest in that, it might be something that you can talk with your families about, that they can create some kind of a model that can be projected. Very simple to do it, projected on the ICU wall that actually can help patients be more oriented. It could be visuals of the family. It could be memories of things gone by that could project on the wall, giving some change in the environment. Just imagine 7 days in an ICU, all the lights are on, lots of noise, alarms going off, and the environment never changes. And you can't differentiate day and night. These are all profoundly anxiety producing. Of course, alarms are also anxiety producing. The patient has no control over their situation. They have physiologic stress, which actually proliferates their anxiety. And by the way, almost every patient who's intubated in your ICU, and a fair amount of them who aren't intubated, are suffering from sleep deprivation. So, I'm a little older now. When I was younger, I could stay awake about 36 hours without really having much cognitive dissonance. Now, if I'm awake for about 25 hours, and I am occasionally awake for 25 hours, I actually see some cognitive failure. Now, I'm not hallucinating necessarily, but I'm asleep while I'm awake. I communicate in an extraordinary way and say all sorts of bizarre things that have nothing to do with the reality. So really is a separation of reality and cognition when you reach some period of sleep deprivation. Remember, most of our patients, unless we are using REM restoring sleep medications, most of our patients, despite the fact they might be at a RASS of -3, -4, -5, that our patients are not sleeping. And this is incredibly important and something that as nurses combined with your pharmacy team, that you can initiate some methodology to assure that patients get some kind of REM sleep. Now that sleep deprivation leads to significant memory loss, plus many of the agents that we use are proamnesic. And, our perspective, oh, well, I'm going to put in a chest tube. We're going to intubate him. He's going to the OR. He's going to have damage control surgery. He's got a wide open ab with a wound vac on. Better not to remember. But I want to remind you that amnesia is not selective. So it's not just that I don't remember the terrible things. I don't remember anything. And so as I emerge from my induced state in the ICU, I'm confronted with memory loss. Sometimes that's memory loss for 2 days. Sometimes that's memory loss for 2 weeks. Sometimes that's memory loss for much longer. This is stunningly difficult for patients to overcome as they resolve from their ICU stay. I don't think it's necessary for me to say, but I do want to remind you that when patients are agitated, pulling on tubes, pulling things off their body, trying to get out of the bed, speaking to them in a harsh tone doesn't really do anything. These are not toddlers that respond to a harsh tone. These are adult patients who have no idea where they are, where typically they think they're being tortured, they've been sold into sexual slavery, they're being raped, they're being abused. Try to imagine when you're communicating that that's what's underscoring their agitation. They're trying to extubate, they're trying to pull tubes out, they're trying to get out of bed, they're trying to get out of the mitts or the cuffs that you've placed on them. And remind yourself that this is not somebody who's going to respond to stern talk, because stern talk is not being perceived by them as anything other than abuse. So really, really important when we think about that. It's also important, of course, to remember that many of our medications that might actually allay some of the anxiety will promote delirium. And in some cases, delirium is hyperactive, so it looks like agitation. And in many cases, actually more than 50%, delirium is hypoactive, which means the person is laying there not expressing anything because they're so terrified, and they are confined within their mind and they're so terrified. This is why we talk so much about what kinds of therapies are actually best for patients. And we are all in pursuit of the best therapeutic advantage to reduce ICU anxiety in our patient population. And by the way, there is no one answer. That's why we come together. That's why we talk about it. That's why I study it all the time, that I'm always looking at what is the best approach for this particular patient, and appreciating that propofol for one might be ketamine for another, might be dexmedetomidine or Precedex for another, might be Versed for another. And that I don't want to just get so invested in this is the way we sedate our patients, regardless of whether or not that's the right agent. So our idea would be to actually try to talk about and choose agents that are going to be important for our patients. So again, just reminding ourselves about this triad, pain, agitation, and delirium, the ICU triad. Remember that the triangle of this, pain promotes agitation, agitation promotes delirium, pain promotes delirium, and in a reverse way. Delirium does not promote pain. Agitation can make the experience of pain much more significant. So that's why our very first goal is to control pain. And we're going to control pain with awareness that just simple intubation is quite painful. And then that might be the injury of the patient, the ongoing process of the patient. Things just like turning patients and doing physical therapy can be profoundly painful. So first and foremost, we're going to control pain. That should help to reduce some agitation. But again, I want to remind you that there are so many aspects. Okay, so somebody has forgotten to mute themselves, and it sounds like it's Eugenia, and it is Eugenia. Okay, so many of our patients actually have very significant sensations. And again, we've talked a little bit about those already. Physical restraint is a really big one. One of the things I tell people is your patient is really agitated. If at all possible, sit them up on the side of the bed. I don't care that they're intubated. They can sit up, intubated. Put their feet on the floor. When they put their feet on the floor, that grounding connection oftentimes will significantly reduce agitation. Now, obviously, you've got a combative patient trying to pull all their tubes, fighting, hitting. You're not going to want to sit them up. But if you see that patients are having cyclical anxiety, it's getting worse and worse and worse, we can really think about the fact that restraining that patient may not be the best thing, that sitting the patient up with their feet on the ground may be quite helpful to interrupt their agitation sequencing. But of course, the most important thing we're talking about today is sedation and analgesia, and how we're going to use that when we're managing our patients. So I like to remind you that sedation is a state of quiet or calmness, right? But agitation is about psychomotor disturbance. So we want to really differentiate these two. And I would myself add in here anxiety. So when we're thinking about our medications, we can think about propofol is fantastic for sedation. Dexmedetomidine is anti-anxiety. To reduce sedation and agitation, and also to treat pain, we may choose ketamine, which is in a class all by itself. So again, having discussion about what the goal is of the medication. Now, when we ask things like that, sometimes it might sound like we don't know what we're doing. So we have to be sure that we contextualize our request. When we're with the team, we can say, okay, I understand that we want to achieve a RAS of this. Are we primarily trying to reduce anxiety, or are we trying to actually sedate the patient and generate like ventilator synchrony, reduction of a seizure foci? What are my absolute goals? Yes, I'm going to titrate to a certain ROS, maybe to -1 or 2, maybe to -3, maybe to -4 or 5. I'm titrating to a RAS when I'm using any of those agents. But there are very different goals with these agents and a very different kind of conundrum that can occur with those different agents. So I do want to remind you, today's talk is really about sedation, not about pain evaluation, and not about delirium, even though those are incredibly important. We have a short time together, so I want to be sure that we're really focusing on sedation and focusing on what our goals are. So we've already talked about what those goals are. Like, we want to be able to communicate. We want to decrease anxiety. We want to improve ventilator synchrony, optimize our patient safety, hopefully reduce the desire to extubate and pull out all their IV lines, get out of bed and run down the hall to get away from us. We really are trying to create a cocoon of safety. And never forget that you would like to promote normal sleep cycles. So again, always start with analgesia, and then we move to sedation. And our goal will be to have the lightest level of sedation possible. So honestly, for most patients, our goal will be to have a sedation level of around -1. We're going to move to -2 or 3 when the patient becomes more and more agitated, when he's putting himself or others at risk. But our first focus will be to have a RAS score of -1. And we're going to do that whenever it's appropriate. Now, if you're going into TTM and I'm going to have you at 34 degrees, no, I'm going to have to put you at a RAS of -4 to 5. If I'm going to use paralytic agents, I need you to be at a RAS of -4 to 5. So again, remember what the goal is today for my RAS score, my sedation score may not be the same thing as it is tomorrow. So first and foremost, of course, control the pain, and then what? Then we are going to be actively engaged. We all want to be experts in evaluating sedation. By the way, this is not that difficult, okay? Is my patient awake, alert, and calm, not restless, not drowsy? That gives them a score of 0. Anything that is incorporates movement or any agitated state is always going to be on the positive side. And we don't ever want, especially our intubated patients, to be on the positive side. If they are sustaining on the positive side, they are not adequately sedated. I'm not going to agree to paralyze a patient who is agitated until he is adequately sedated. In my own institution right now, I'm in the midst of working with pharmacy to write a pathway that assures the support to bedside nurses that they can assure patients are adequately sedated before administering paralytics. We will never give a paralytic to control agitation or combativeness if what we're giving isn't working in terms of sedation. This is just like using vasopressors, my friend. When 10 of norepi doesn't work, 20 probably won't work, 40 won't work, 60 won't work, 150 won't work. It's the same agent and it's not working. So if I have a patient who's on propofol and I am not able to control the patient, I'm going to think about other agents that I can add. Can I add ketamine? Can I give Versed boluses and then perhaps a low-level Versed drip? I have to actually be creative here, not just keep going up on the same agent when it hasn't worked. And that, my friends, is our responsibility as bedside nurses, to assure that we are attempting to contextualize our patients' agitation, to keep them safe, to keep them comfortable, to keep them as best we can pain-free and fear-free, because almost all the agitation that you see here actually ends up being a fear and catecholamine response. Now, look how easy this is. You're -1 if you're sleepy, but if I say, open your eyes, I ask you once, you can keep your eyes open for 10 seconds. If you are drowsy, I can wake you up, but you cannot keep your eyes open or in eye contact for 10 seconds. So 10 seconds or less, that's a -2. If you are moderately sedated, I may be able to wake you up, but you can't look at me and you can't keep your eyes open. So, Mrs. Smith, open your eyes. Eyes pop open and close again. That's really a moderate sedation. That's -3. Now, for most of our patients, we want them here, -1 to -2. We move into moderate sedation of -3. And then patients who actually don't, and you can only do one thing at a time. So I'm going to use verbal stimulus first, physical stimulus after. I'm not going to use verbal and physical at the same time. I have to evaluate, can you wake up to verbal, or do you require physical stimulus to wake up? So if you move around, you're not really opening your eyes, you're not maintaining eye contact, but if I stimulate you physically, you move around, that's considered deep sedation, -4. And even if physical stimulation, you are not waking up, that is profoundly deep sedation, that's -5. Okay, so again, what I want to remind you is we really want to keep our patients -1 to -2 with fairly light sedation. That lighter sedation is going to long-term be better for our patients. We have to evaluate sedation at the very least every 2 hours, and at the very most every 1 hour, because sedation changes depending on the patient's metabolic rate, what else is going on, do they have acidosis, are they using vasopressors? Sedation will change even though you haven't changed your drip. So this is a very dynamic evaluation score. Now, some folks are going to use a BIS monitor to evaluate sedation. That's great. If you're doing BIS to evaluate sedation, you know that the lower the number on the BIS, the more sedated the patient is. And typically the target is somewhere between 40 and 60 on the BIS monitor. Everybody doesn't have BIS. Even when you have BIS in your institution, you don't have one for every patient, but everybody can put into evaluation our Richmond agitation sedation scale. Now, it's really easy to knock patients out. And historically, what we've done in critical care is knock patients out. But what we really want to do is we want to keep patients calm, right? We don't really want them to be unarousable unless we have a particular purpose for that. I'm using neuromuscular paralytics. I have you in TTM, you're in extreme ventilator dysynchrony. I'm going to sedate you to -4 to -5, and then I might consider paralytics. But I'm always going to sedate you first and see if I can achieve better control with sedation before introducing paralytics. So when we ever think about sedation, remember the quadruple C's. Most important, I want my patient to be calm, comfortable, cooperative, and communicative, if at all possible, with the agent that I'm using. I also would like to remind you that if possible, you'd like to have minimal respiratory depression when you're sedating patients. Now, our older sedation methodologies, benzodiazepines, and in particular, Versed, or Propofol, actually have significant respiratory depression. And the higher the dose, the more respiratory depression you're going to have. Now, your patient's intubated and you're controlling them with the ventilator. So you're not worried about this like you would be with procedural sedation. But it is important to remember, and I think something that we don't think about very much, is that the diaphragm is an incredibly muscular organ that must actually be exercised. And it's an organ that can actually be rapidly broken down when it's not being utilized. So really important to remember that even though I can control you with the ventilator, I still would like for you to be able to have some capability of diaphragmatic contraction, even if it's SIMV with a pressure support of 15. I'm very much supporting you, but I'm still asking your diaphragm to function and produce some work so I can maintain diaphragmatic integrity. So when it comes time to wean, it will be a little bit easier. I also want to remind you that what we really want is, if possible, to actually be able to retain natural sleep. And we'd like to have some reversible agents. And typically we would like to be able to induce some amnesia. Okay, I'm realizing this case is a little out of context because the first thing I'm going to talk about is benzos, but I just want you to see this patient on CRT, and this is what it looks like at his filter. He's on a Prisma Flex. He's got a filter of 150. That's a really high clearance filter and large bore membranes. And what you're seeing here is lipid. This is all lipid. This is a 74-year-old male, past history, hypertension, stroke, end-stage renal disease, on hemodialysis outside of the hospital, type 2 diabetic, not well controlled. He has chronic kidney disease-based anemia, and he comes to the ED. He's got fever and cough for 3 days, got crackles bilaterally, very significant bilateral interstitial infiltrates, admitted to ICU because he's severely hypoxemic, does not respond to a mask, does not respond to high flow, does not respond to CPAP. He's not hypercarbic, he's just hypoxemic, does not respond to CPAP. So he gets intubated, start on propofol and fentanyl for sedation and analgesia. And of course, the diagnosis is sepsis, and he loses vascular tone. So he's got wildly up and down norepinephrine and epinephrine and support with vasopressin. Because he's lost his vascular tone, he has septic hypotension, develops significant multi-organ failure. He already had multi-organ failure, he's on vasopressors, but now he develops kidney acute on top of chronic kidney injury. Acute on chronic kidney injury, almost always deadly. So CRT is initiated. Day 1, you're getting an alarm for extreme positive pressure on the return side. That means that the machine is having to force, really against all odds, trying to force blood back into the patient on the return side. And on the access side, so I would just basically say red line access, blue line return, all venous, red line access, blue line return, that the console is having to generate a very significant negative pressure. And that's that blood pump that's turning really rapidly and hard to try to suck blood out of the patient. The nurse says, hey, yeah, my filter is excessive pressure. I'll have to return the blood. I'm going to take the filter down. I go and I look at the filter, and oh my God, it looks like chocolate milk up here. And all through that tubing. And then there's this layer of fat on the top there. Okay, by the way, the next filter I put up, the same thing's going to happen because I've got a problem. So the discussion is, okay, let's really evaluate our patient, because what we're looking at here is significant amount of fat. So a triglyceride level is drawn, and triglycerides are 930 and normal is 149. This was very common in the older manufacturing of propofol, where triglyceride or lipid level was much higher than it is now, but it is still transported via lipids. So it's something we're always going to be aware of when we're giving propofol. So you can see very significantly that little fat layer and the chocolate milk in his tubing. Okay, so first and foremost, here's a person where we're going to talk about, well, propofol may not be right for this patient. He's got lipids, that a very high level of triglycerides, that's going to interfere with cellular metabolism. It's going to cause cardiac dysfunction. It's going to cause renal dysfunction. So let's talk about benzodiazepines. Well, I'm sure anybody who has a child under the age of 5, or anybody who loves Disney is going to recognize that this is Barbara's take on We Don't Talk About Bruno from Encanto, but it's, we don't like to give benzos. No. Benzodiazepines are older agents. And so we feel like we have better profile agents. The reason we don't like to give benzos is because benzodiazepines significantly reduce time spent in REM sleep. Now, patients look like they're sleeping for a long time. They have a reduced number of awakenings, and they have increased time in stage 2, which is not REM. Stage 3 is REM. Now, who cares about REM? All of us. REM is when you turn over proteins. REM is when you restore. REM is basically, for lack, and please forgive me, not very scientifically, I'm going to say REM sleep is when your brain actually depolarizes all of what's happened that day and renews itself for what's to come. REM sleep is incredibly important, and the lack of REM sleep is highly contributory to the length of stay, the stay on a ventilator, mortality, morbidity, and the incidence of delirium. This is why we don't like to give benzos as a first-line agent. So in a really great study from like 2001, very nice study that did some comparative analysis between lorazepam, midazolam, fentanyl, morphine, and propofol, and looking at the transition odds to delirium. Of course, you're going to see here that midazolam was the highest incidence of transition to delirium, and a really important factor. Lorazepam separated all by itself, just lorazepam, but not looking at other issues. Lorazepam was also an independent risk factor. So out of this study came the perspective that, in general, benzodiazepines significantly produced the concept of delirium. Now, for us, delirium is, okay, you're either really asleep and hypoactive delirium, or you're very agitated and hyperactive delirium. But I want to remind you that delirium is about the loss of perception of reality. That's what delirium actually is. I do not perceive reality. Now, that means that whatever you're doing for me, I perceive as you are doing to me. And there's a big difference. You're cleaning my ureteral area and my rectum and my back, but I feel like you're exposing my genitals because people are bidding on me. This has been so highly discussed by individuals who have actually had delirium. About 11 years ago, we had a young patient who was shot at his birthday party. Not anybody in anger. I just think people were like saying, look at my gun, look at my gun, look at my gun. And he was really quite critical, and he spent quite a bit of time in our surgical ICU. And I was very involved with them because his family participated in the family meeting. And by the way, his wife was my dental hygienist. So when he was admitted to Grady, she called me, and I was pretty involved with them. And kind of watching him through the process, he developed very significant ARDS. Part of that was post-transfusion ARDS. Part of it was related to his inflammatory injury. We put him on a road arrest bed. He stayed in the ICU for about 8 weeks, and 6 weeks of that he was under propofol and fentanyl management. It took him 3.5 years before he could even talk about his experience. And he came back. I had a big meeting, bringing back 5 families from family meeting to talk to providers about what it was like being a patient or a family member in the ICU. 2 of the families, their loved ones had died. 3 of the families, their loved ones survived. I'm actually looking at a picture of this family meeting, this through the Southeast chapter, what we expressed. And I'm remembering so very clearly the experience of all of the patients who were survivors, of their perception of the reality. And 2-1, it was a perception of abuse. So first and foremost, we will use benzodiazepines when they are necessary, but I want to make sure you appreciate that by instrumenting benzodiazepines, you have now made a commitment to fully, effectively, resolutely, and at the very least every 12 hours, but at my perspective, every 2 to 4 hours, you should be evaluating patients for delirium, and in particular in relationship to benzodiazepines. Now, benzodiazepines are used very commonly for patients who have increased intracranial pressure. Sometimes we see Versed at 80 to 100 milligrams an hour of Versed in those patients, trying to control ICP and to control agitation to keep the ICP down. But in conjunction with that, it becomes very hard, of course, if you're a head injured patient, for us to evaluate you for delirium. But our responsibility is to actually practice delirium assessment and to assure that we know what we're doing, and that the importance of evaluating delirium in these patients, in particular, not just on benzos, but also, of course, on propofol, really evaluating those patients effectively. And by the way, spoiler alert, Precedex and ketamine do not promote transition to delirium, which is why many of your physicians are choosing, or your providers are choosing ketamine and or dexmedetomidine Precedex to actually help assist patients with their anxiety and their pain. Ketamine for pain and anxiety, of course, propofol for only anxiety and sedation. Dexmedetomidine only for anxiety and sedation. So really important for us to appreciate that many of these decisions are made based on risk for delirium. So I do want to remind you about Versed. It's a short acting, it's 4 times more potent than Valium. You know, Valium is the great grandmother of benzodiazepines. Really, nobody uses that. We certainly don't use it in the ICU unless you have no other options. If you need benzodiazepine, the benzo of choice will be Versed because it's short acting. Very quickly, it will produce sleepiness and a reduction in catecholamine traffic, so therefore a relief of apprehension. Onset of action, 3 to 5 minutes, really nice. It gets to work very quickly. And the half-life can be anywhere between 1.2 to 12.3 hours, depending on the dose and also depending on the continuum. So one really important thing that I want to say about Versed, if you are using Versed, you're using benzodiazepines to sedate your patient. Again, if I'm using that, I'm going to up my delirium evaluation. I'm going to be really aware of that because that's going to be my biggest concern here. The other thing is I want to remind you that in order to control your patient's agitation, they're unsafe, they're acting unsafely. In order to control that agitation, you need to bolus again in 5 minutes, bolus again in 5 minutes, bolus again in 5 minutes, and after 4 boluses, you increase the drip. If what I'm doing at the bedside is increasing the drip, but not bolusing the patient, I'm actually saying it might be 12 hours before I actually achieve the level of sedation I was looking for. And now they're going to be way over sedated because I kept titrating upwards. You have to actually reach all the receptor sites. You do that with boluses. So in general, and again, at your hospital, you should know what your methods are. You should have discussion with your pharmacy team. Here, the recommendation, here at Grady, the recommendation by pharmacy is bolus with 2, 5 minutes, 3 to 5 minutes, bolus again with 2, 3 to 5 minutes, bolus again with 2, 3 to 5 minutes, bolus again with 2, and increase your continuous drip. Not bolus and increase the drip. Because what's going to happen is as you're increasing that drip, you're not going to achieve that anxiety control without the bolus. And if you're also going up on the drip and you're bolusing and you're doing them both at the same time without actually recruiting the receptors, you are ultimately going to end up 12, 24, 30 hours from now profoundly oversedated. And that means even if the patient might have been ready to be extubated or to have sedation assessment and sedation reduction, sedation vacation, you're not going to be able to achieve it. So part of the importance in using Versed is to really understand how you're going to use it to help control anxiety and sedate your patients. So remember the that's the propofol, right? We all love propofol because it works really fast. The onset of action is 30 seconds. Half-life is 2 to 4 minutes. Quick on, quick off. Very important to appreciate that most of us as nurses are actually supported to use moderate sedation. Okay, now thinking about doing RSI, thinking about procedural sedation, I'm not really talking about that. I'm talking about management of intubated, ventilated patients. So typically the Board of Nursing pharmaceutical direction is you're going to increase your propofol in order to effectively help control ventilator dysynchrony and reduce anxiety. Which means, my friends, You're not just going up on the propofol, you're actually documenting a RAS. You're actually aware of what the RAS schedule is. You have a RAS goal and you're titrating to achieve that goal. So your physician says, I want you to titrate propofol to a RAS of -3. That doesn't mean I want my patient unconscious, right? I have to understand what the RAS score is, and that's what I'm titrating towards. There's a lot, depending on the patient, their age, their metabolic rate. There's a wide range of appropriate sedation with propofol. Okay, so really important for us to remember is, number one, you should always expect that your blood pressure is going to drop. Typically, and it's always concerning, is because I'm actually going to promote vasodilation with propofol. I also can promote bradycardia. So if I have bradycardia and vasodilation, I'm going to have really significant and profound hypotension. Okay. Thiopental, you're not using, don't worry about that. Okay. Very profound respiratory depression, and that typically right after induction. So I'm giving you an induction dose in RSI, you're going to have a period of apnea. Once you're ventilated, I'm going to control that. So I'm not so worried about that, right? You're intubated, you're on the ventilator. I'm not really worried about the profound respiratory depression. I'm just looking at what that might mean over time. You actually have some smooth muscle relaxation. So your conducting airways typically do not constrict. You might see that with benzodiazepines, typically don't see that with propofol. But because you dilate your vessels, the blood flow to your brain goes down. Now, when the blood flow to the brain goes down, your intracranial pressure will drop immediately. But the problem is, if your blood flow went down, you are ultimately going to be ischemic. So eventually your ICP may rise. We're not so worried about anti-emesis. That's usually about outpatient anesthesia. It is an excellent agent that we can use safely in patients who have epilepsy or who are having seizures, and we can also use it to control seizures. So that's pretty great. I don't think any of us are that worried about intraocular pressure, but what we should be worried about is propofol infusion syndrome, and that's really what I want you to focus on: propofol infusion syndrome. It's been increasingly reported in adults. It was first identified about 18 years ago. It was quite common in procedural sedation, relatively common in pediatric patients, but it's becoming more and more reported in adult patients. And take a look at this. Consider propofol infusion syndrome, or propofol response infusion syndrome, with unexplained metabolic acidosis. And because of that metabolic acidosis, some hyperkalemia, and because of cell lysis interference at the cellular level, because of the lipid transport, that the lipid transport of the agent actually interferes at the metabolic level of the cell, you can actually see an extension of your myocardial infarction, myocardial dysfunction, muscle lysis, and ultimately acute kidney injury. So when we say rhabdomyolysis, remember that's muscle lysis, and then the spilling of the skeletal muscle, the spilling of iron into the system, then promotes acute renal dysfunction. So I want to make sure we are appreciating this, okay? You have sustained metabolic acidosis. That means you've lost your vascular tone. I'm titrating up on your vasopressors, but you're on propofol and you've been on it for 4 days. Okay, first thing I'm going to think about as the bedside nurse, is this possible propofol infusion syndrome? Okay, if it is propofol infusion syndrome, now I'm remembering it isn't actually response, it's PR for propofol, because nobody wanted to call it propofol infusion syndrome, which then said PIS. So that's why we have propofol PR infusion syndrome. Okay, I forgot that, so sorry. But when I draw your blood, I can actually see lipid when I'm drawing the blood. Now, typically you'll have a large liver. I may or may not notice that. You have rhabdomyolysis. That means your CK is going up. And because you're releasing iron pigment into the serum, that iron goes through the blood into the kidney, and it causes destruction of the tubular walls of the kidney. That's what causes acute kidney failure. But you should be thinking, I'm on propofol and I'm on it more than 24 hours. I have refractory metabolic acidosis and hyperkalemia. Those are the first two. When I draw your blood, I see some lipid in the blood. I should be discussing at this point, is this propofol infusion syndrome? Which means, guess what? turn off the propofol. Got to go to something else. Might be Precedex, might be ketamine and Precedex, might be benzodiazepine. I need to be aware of the problems with propofol because we use it like it's water. And we think the worst part of it is respiratory depression, but you're intubated, so we're not worried. But that isn't the worst part of it. It actually is really related to these free fatty acids and their interference with the ability for me to metabolize. So lots of risk factors for propofol infusion syndrome, and you can see them here, right? Very important to see the younger the patient, the more at risk they are because of the metabolic integrity at the cellular level. So really, really important not to assign that to our elderly patient. It's usually related to being a little bit younger. If you are receiving propofol and you are receiving corticosteroid therapy, such as you might be if you were in the neuro ICU, or if you have acute exacerbated asthma, so you're in the MICU, we need to be really, really aware of that. But the biggest thing we should be aware of is prolonged propofol dosing. So we think about all of that relationship, more than 4 milligrams per kilogram per hour, or more than 48 hours. Are you getting catecholamines, epinephrine, norepinephrine, eosinophil? Are you getting corticosteroids, Solu-Cortef, Solu-Medrol, Decadron, fluorocortisone? And do you have critical illness which might interfere with your ability to break down these lipids? These are patients who are at risk for propofol infusion syndrome. Okay, case number 4, 70-year-old female scheduled for abdominal aortic aneurysm resection reconstruction. She's had general anesthesia over the last 6 years or so, had no problem, didn't have malignant hyperthermia, didn't have any kinds of problem. She's 142 centimeters tall and her weight is 54 kilograms. She's induced with remifentanil, which is a shorter acting form of fentanyl that's only really used in the OR, and propofol was started IV with a target plasma concentration of 3 mics per mil. So her operation, which was supposed to be over in about an hour and a half, actually was extended because she started bleeding from a little transection or a clip to her lumbar vein, and the anesthesia lasted 5 hours and 38 minutes. Second post-op day, she's oliguric. She is breathing 45 times a minute with respiratory distress. Her chest X-ray shows pulmonary edema. She gets re-intubated. She gets bolused, not bloused, bolused with 30 milligrams of propofol and maintained with propofol at a rate of 50. The next day, she has a fever. She drops her blood pressure. Her platelets have dropped because she's using them in this inflammatory cascade, but most telling is her CK is abnormally high. When she gets a blood gas, her pH is 7.4. Her PCO2 is 23, which means she's compensating. She's breathing fast, blowing off CO2. Bicarb is 14, which means metabolic acid is elevated. Base deficit is -9. Her anion gap is wide. Okay, now I talk about all these things all the time. Your patient has acute metabolic acidosis. Now, it's really easy to look at this and say, she has pneumonia, she has some other kind of problem, she has sepsis. But indeed, my friends, she has propofol-related infusion syndrome. She has propofol infusion syndrome. Now, we know when we take a look at her, so look at her data here. So she was very nicely kind of alkalotic. She maintained her pH, but she only maintained her pH because she was blowing off CO2. Her bicarb dropped. Her base was in significant and profound deficit. This is where it's the worst, right? And her anion gap is elevated. So I'm looking at these 3 things: bicarb, base, gap. Your patient has metabolic acidosis. She's compensating by breathing fast and breathing deep. And we can see, of course, that she's hyperthermic and her lactate's not really that elevated. I'm not that worried about the lactate. I am worried about her total CK. So I want to just show you, propofol went off and look what happened. So she peaked to 41. They turned off the propofol, temperature dropped almost within 24 hours, right? Her total CK, which maxed at about 50, right, about 52 or so. And as soon as the propofol was turned off, she drops right down. That was fantastic. And it was a great case in point for propofol infusion syndrome. Okay, how about Dex? Okay, Dex is fantastic. Dex is for hyperadrenergic patients. Okay, if you're hyperadrenergic, here's what I expect. You're going to be agitated. Okay, well, I might give you benzos, I might give you propofol, or I might give you Precedex, I might give you ketamine. But what I see here is tachycardia plus systolic hypertension. This means you're hyperadrenergic. So trying to sedate you with benzos, trying to sedate you with propofol, it might work. It might work. But what I really want to do is I want to use some alpha agonist therapy, and that's going to be Precedex or clonidine. And for us, it's going to be Precedex, right? Central alpha agonists are not like other sedatives. Why is that? So I'm just going to say most of us are not going to use clonidine. Some people use Klonopin for anxiety, but in our ICUs, we're going to use dexmedetomidine or Precedex. This is a really selective alpha-2 agonist. And what that means is it's going to help control your anxiety without respiratory depression or hemodynamic instability. So that's really, really important. Don't look for the same result with Precedex that you get with propofol. When you give propofol, you are inducing anesthesia. With Precedex, you are reducing anxiety. I wish I had a Precedex drip every time I got on the plane. I would give myself a little bolus of Precedex. I'd be calm, I'd be comfortable. It would wear off really fast. I'd be able to get off the plane and go lecture. Instead, I have to try meditation, tapping my head, tapping my thighs, tapping my chest, because I can't take any benzo because it makes me depressed. So don't want that because I got to get off the plane and lecture. Precedex is a beautiful agent to control anxiety. So really, really important for us to appreciate. I don't expect the same thing from Precedex that I expect from a benzo or that I expect from propofol. If you implement that in your mindset, it really changes the way you see Precedex. Now, it's fantastic, right? Doesn't make your ICP go up or down. Doesn't decrease, it does decrease metabolism, it does decrease oxygen consumption, it does not promote amnesia, but it significantly and profoundly reduces anxiety. And because of some of the catecholamine uptake that this affects, what you expect to see is a reduction in heart rate and some neuroprotection. So very, very important. Now, these are hyperadrenergic orders. So just remember how you mix your Precedex, right? And we're going to give it to patients who appear to be hyperdynamic. So I might think about, I'm going to use this in conjunction with propofol. I might use it in conjunction with Versed to reduce the hyperdynamism. But I can also use it to reduce anxiety without significantly promoting sedation. So we want to remember how we're actually going to give this, right? Basically, we're going to increase our increments every 20 minutes, and we're titrating to a RASS goal or to a heart rate goal, okay? Always important to remember that if your patient has significant bradycardia, you can't go up on Precedex anymore. The limitation of the catecholamine has now expressed itself in bradycardia, and we don't exceed 1 mic per kg per hour without a specific order to do so. So it may be that your order set already allows you to go to 1.2 here at Grady, 1.2, but beyond that, you must have a particular physician order. And it's really, really important for us to remember that. So when we think about the hyperadrenergic order set, yes, we have RAS, but we're also going to think about our heart rate, and secondarily, we're going to think about our MAP goal. So again, for the backseat, going to load patients with Precedex 10 in a 10-minute loading dose of 0.5 to 1.0 mics per kg over 10 minutes, and then we're going to maintain you over time, and we'd like to reduce you to a lower level once we basically have captured you. Okay, now last but not least is the future, and I'm going to talk about this quite quickly. I think the future Sometimes I say those who forget the past are doomed to repeat it in the future, but here the future is the past. Ketamine is probably one of the most interesting agents that we use. It is what I would call, and I would remind you when you hear this term, I talk about a dirty drug. A dirty drug means that it is dose specific and it does a wide variety of things related to its dose. That's similar to dopamine, that's similar to epinephrine. These are dirty drugs. That means you actually have no idea when you get started what you're actually going to see as an end response. You have to look at the patient. You have some idea, well, this dose affects that and this dose affects that. We do have some guidance on this, but I want to remind you that dosing with ketamine has to be done with a lot of focus and awareness. Dose-related effects. So if you take a look here, what you're seeing here is analgesia is typically 0.1 to 0.2 milligrams per kilogram. As you get a little bit higher, you're going to have, your patient is actually going to feel like they're high. They're going to express to you that they're feeling high, and they're going to start to dissociate from reality. And, sometimes that's not a terrible thing. It's important. I'll probably have that later in another slide to remember that ketamine is a PCP derivative. So think about patients coming to ECC or your ED high on PCP. At a high dose of ketamine, that's what it's like. Patient is completely dissociated. Patient is completely isolated from all external stimuli. The only difference here is patient is dissociated. He is happy as a clam, but he can't communicate with you. He's disengaged. He's drooling. He's acting like a newborn baby. His whole physiology is dissociated. So quite honestly, I'd rather be here, 0.1 to 0.3, or here. I don't really want to be in this because now the patient is really actually hallucinating and it can be aggressive. So we love ketamine because it gives us profound analgesia and it gives us some very significant control of anxiety while preserving skeletal muscles, preserving cardiovascular tone, cardiac response, respiratory response. So we can use ketamine typically without any secondary cardiac or respiratory effects. It's short acting, right? It takes place about within 5 minutes of administration of your first bolus dose, lasts for about 30 minutes. Always be aware that it is metabolized in the liver. So if you've got hepatic dysfunction, you have to be very cautious and probably won't give ketamine. And it's excreted. The secondary products are excreted in the urine. So if you have AKI or chronic kidney disease, you may not be able to give ketamine. So when we think about all these organ effects, so basically what this is going to do is you're going to have an increase in cardiac output. Typically, you see an increase in systemic blood pressure, may have some bronchodilation, but you do not see typically, only if you're giving it really quickly or at a high dose, will you see a loss of respiratory reflex. It's really, if we're dosing correctly, it really is a profoundly functional agent. It is profoundly functional. So in an anesthesia article that is from 2023, and I'm happy to share that with you, where there's discussion about ketamine, just some discussion about controlling patients during intubation. So in your RSI, the utilization of ketamine, so you're using a little bit higher dose here of ketamine, and because you're using that higher dose, you're going to give a bolus. And you don't want to give that bolus too quickly. Remember, rapid bolus can cause really significant dissociation. But even if you're giving slow bolus over 5 to 10 minutes, you should confer with your pharmacist. You still may see some dissociative effects, some hallucinations, disorientation, et cetera. That will generally disappear, although the memory of it will sustain. It does give analgesia, amnesia, and sedation all in one single agent while allowing my patient to be hemodynamically stable and allowing them to breathe. So this is why ketamine has really come back into favor. It is a very significant agent for analgesia. This is at a much lower dose than what we use to control your airway for intubation or RSI, much lower dose and continuous infusion, but you can still, of course, see dissociative effects. So again, if I'm using ketamine and my patient is acting all agitated, that does not mean go up on the ketamine. That means ketamine is the wrong agent for the patient. And we've got to go to something else. We've got to go to Precedex and Propofol or benzodiazepine, but ketamine, if my patient is acting agitated, is typically, it's not the right agent for that patient. Now, if I am using ketamine and my provider really wants to use ketamine, I can actually give benzodiazepines, which will reduce those dissociative effects in patients who are receiving ketamine. What I really love, though, is this idea of being able to use it for agitation and delirium. Much faster control for agitation. And what's really beautiful, because you could do it pre-hospital, I'm not recommending that, you can use it for rescue medication in the ED because it can be given sub-Q or intramuscularly. So this is the dosing for intramuscular, 3 to 5 milligrams per kilogram bolus IM, but a little bit lower when we're talking about IV. Okay, for agitation and delirium. Can also be used for procedural sedation, again, at a lower dose. And at that low dose, what you can see on recovery when you've done this for procedural sedation is confusion, anxiety, and hallucination. So, you know, I'm kind of an old person. 35 years ago, no, probably 42 years ago, I had all 4 of my wisdom teeth pulled. I was at Piedmont Hospital. I had a oral surgeon pulled all 4 of my wisdom teeth, and they had administered ketamine. Now, people at Piedmont knew me. I'm in the PACU. I wake up screaming, "Get me out of here. You're hurting me. Help me, help me." I'm screaming at the top of my lung. Everybody knew me. And I'm screaming, and I'm like trying to climb over my side rails. I was so agitated. Plus, I had these recovery reactions. So again, the thing that this is going to respond to is just a quick, one-time only bolus of benzodiazepine, particularly Versed. Other things that we can use, you can see all these different doses. Happy to share all this with you. It's very beautiful in the literature and really easy for us to follow. But I also want to remind you that it can be significantly used when you are withdrawing patients from alcohol, can significantly reduce severe withdrawal syndromes and symptoms, and it is highly related to reduced ICU time. There are, of course, adverse effects. Now, the most important one is that ketamine is actually again, it is a PCP or NMDA cousin. And so it actually causes an increased release in catecholamine. That's why the heart rate goes up and the blood pressure goes up, which makes it a great choice in somebody where you need to maintain or increase their cardiac output, where you need to maintain or increase their systolic blood pressure. Fantastic, right? But just balancing that with everything else that's going on when you're thinking about the utilization. And then also just to remember this whole perspective that because of this catecholamine release, just reminding yourself that similar to PCP, similar to NMDA, similar to cocaine, that the patient may be very disoriented, may be very dysphoric, may have very significant hallucinations. And when this occurs with ketamine, this is best going to respond to midazolam, to a midazolam bolus. So again, don't be afraid to give ketamine because it really is a fantastic agent, but also be prepared that if necessary, you're going to give a bolus of benzodiazepine, and that should be part of your order set as a secondary control agent so that you can administer it if the patient is expressing that. So it is quite perfect for difficult airways, very perfect for patients who are hypoxic, who need RSI because you don't want to completely limit their respiratory response. It's a great agent to use, actually is used in centers around the world for substance withdrawal. So it's a really great agent to use in opiate tolerant patients, opiate abusing patients, really strong patients, because remember, we talk about ketamine once upon a time as being a horse tranquilizer. It really significantly reduces kind of the desire to be harmful. It promotes bronchodilation. It can be very, very helpful. And there's likely many other purposes and long-term utilization. I just want you to be aware, this is dirty dosing. Dirty dosing means I'm not sure what's going to happen when I give it. It really depends on your receptor sites. So typically I'm going to try to start on the lower end before I go any higher, because what I really want to do is support analgesia, amnesia, and sedation without significantly producing dissociative effects. So if we just take a look at these clinical effects, I added ketamine here, so I don't have a link. These are old because all these agents are pretty darn old, right? So if you look at benzos, sedation, alleviate anxiety; propofol, sedation, facilitate ventilation; opioids, sedation and analgesia; alpha agonists, everything; ketamine, everything, and in particular, controlling delirium. So quite honestly, I would tell you that these two agents in a general framework are the agents of choice. Never think that you shouldn't give an opioid. Never think that you shouldn't use propofol. Never think that you shouldn't use benzodiazepines, but open your arms to embracing alpha-2 agonists and ketamine. So dexmedetomidine, Precedex, and ketamine in your practice. Be aware that there is a significant shift towards Precedex and or ketamine. Really, really important. So now we're going to look at this patient, 64-year-old man with past medical history, significant for hypertension and diabetes, admitted ICU after falling 10 feet from a ladder to the ground. He didn't hit his head, but he does have multiple rib fractures with a flail chest segment and requires intubation for respiratory failure. Orders are for propofol infusion and fentanyl infusion, one for sedation, the other for analgesia. On day 2 of admission, he's agitated and finding the ventilator, which leads to hypertension, tachycardia, and hypoxia. What do you want to add? And you know what the answer is. He's got hypertension, tachycardia, and hypoxia. He's hyperadrenergic. You need to add Precedex. You might consider ketamine, but the probability is you're going to add Precedex, or you're going to ask for Precedex. Always remember that when you transition from sedation, you should never, ever, ever do cold turkey. You got to wean these agents at a controlled rate, and in particular, propofol. If your patient becomes agitated during weaning from sedation and you don't want to go back up on that agent, or you have secondary effects that you don't want to go up, you should consider using another agent. And we're always going to attempt first to wean and remove continuous narcotics. 6 final points. Dexmedetomidine as a mechanism of action, different than benzos, different than prop. It's alpha-2 receptor selectivity, a lower risk of hemodynamic adverse events, comparable sedation to benzos, but behaves differently. Patient still responds to stimuli, can cooperate, can communicate, and that's way better than patients on midazolam and or propofol. Ketamine is a PCP NMDA derivative, does not put the patient at risk for increased ICP or delirium, and does not promote hemodynamic instability. Dex or ketamine, less respiratory depression, easier to titrate and wean patients off ventilation. Dex and ketamine, delirium is less frequent in both of those, either one of those, than with midazolam and or propofol. Remember, if you're using midazolam or propofol, you as a bedside nurse have made a bigger commitment to evaluation of delirium. Time to extubation with either Dex and or ketamine is going to be much shorter than with midazolam or propofol. So quiz time. This is from the Anesthesia Residency Guidebook. Propofol-related infusion syndrome is characterized by all of the following except non-gap acidosis, renal failure, bradycardia, and rhabdo. So ding, 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 except letter A, your patient will have a wide gap metabolic acidosis. So this is not the answer. That is the answer. A is the answer because it's not that. Dexmedetomidine is associated with all of the following except the EEG is similar to a normal sleep cycle. You maintain your respiratory drive, tachycardia, or decrease in ventilator-dependent days. Well, dexmedetomidine does actually put you into a much more normal sleep cycle. It does help you maintain respiratory drive, but because it's an alpha-2 agonist, you actually have bradycardia, not tachycardia. So the answer here is tachycardia. The end is near, my friends. Just remember, control pain first. Control pain first. Use opioids unless it's neuropathic pain. If it's neuropathic pain like back pain or sciatic pain, you're going to use neuropathic pain management like gabapentin or tramadol or something else. Routinely monitor your patient's sedation levels, not once every 6 hours, not once every 8 hours, at the least every 2, and at the most every 1. Okay, because that changes. And remember, lighter sedation actually leads to better outcome. Benzodiazepines in general are no longer the agents of choice for sedation because they are highly associated with acute delirium. Dexmedetomidine can be associated with much lower incidence of delirium and decreased time to extubation, and the same thing with ketamine. Ketamine is one drug, fits all categories: analgesia, amnesia, and sedation. And then just remember, you can always go to SCCM and look at the bundle for best practices for management of patients who are on mechanical ventilation. May the calm be with you, my friends. Thank you so much for joining me today. I'm going to stop recording, but then I'm going to open my window for a discussion. And I have really only about 2 minutes. All right, my friends. Thank you so much. Thank you for attending.